Good afternoon. I think we are ready to start because I've just got a thumbs up there. Yes, we are all ready to start. So good afternoon, everybody. Thank you very much for joining us this afternoon for our staff webinar. And what we want to do is just go through today a bit of an update on where we are with the new hospitals development. So joining me today is Abbas. So Abbas is our clinical lead for redevelopment. Tahir, who is our data lead for redevelopment, Sarah, who is the communications lead for the redevelopment, and then myself, Jason, and I'm the SRO, Senior Responsible Officer for the redevelopment. And as you can see, we've got a brand new little logo in the top right hand corner. So there you go, the new Hillingdon Hospital. What I want to do just to start with is say a huge thank you. If you look at the last 2 years, it has been absolutely sort of testament to all the hard work that's been done. Sorry, you just lost me. Can you hear me again? Good, yes. So we had so just about the health infrastructure plan, those 40 new hospitals for England, with Hillingdon being named one of them. Following that announcement, there is a business case process that we have to follow in line with sort of Treasury guidance, which sort of consists of a 3-stage process: a strategic outline case, an outline business case, and a full business case. The strategic outline case we had approved in 2020. The outline business case is the stage we're currently at, so that we're looking for approval in 2021, with a full business case in 2022. A key component of the outline business case is the design of the hospital. So there's something that Tahir will go into more detail later on in terms of what's called the 1 to 500 design, which is sort of the big picture design. And then there is something called the 1 to 200 design, which is that next iteration down of a more detailed hospital design. And Abbas will be updating us on the process for that going forward. And then if we look at next month, we're also going to be sort of providing a lot more information we'd like to share with everybody and to get people's feedback. So if we just go on to the next slide. So developing a new hospital. One of the key components of developing a new hospital is our clinical services strategy. So again, key elements around this was that our clinical services strategy we developed, and it was approved in April 2020. And then the key components going forward is we're working very much at a national level. So obviously with the NHS, there's lots of national guidance, and ensuring that we're adhering and incorporating all that national guidance into our latest thinking. There is a team called the National New Hospitals team now, which is Department of Health and Social Care staff, plus NHS England and improvement staff, and we're working very closely with them. Then at the other levels, we've got the sort of Northwest London integrated care system level, so very much working collaboratively across Northwest London. And currently we're updating the acute strategy for Northwest London with that. And then what is now referred to as place level, we've got Hillingdon Health and Care Partners, where at that sort of local Hillingdon level, we're working with our GP partners, the community and mental health trusts, CNWL, voluntary services, the third sector in terms of other providers, and sort of the health watch as well, just to ensure we're working very much at that with all local partners. And then that last piece about all our other strategies and making sure that we tie together. So very much around education, research, therapies, We're also updating our digital strategy, our estate strategy and our workforce strategy. So a huge amount of sort of support work around the strategy, which will inform the design. The key parts around that is what we see currently at Hillingdon is sort of what was referred to as that sort of district general hospital model. So in the 1960s, a sort of national policy of district general hospitals across England, and we're very much working with a number of other partners now of what does that next generation of district general hospitals look like, with us at the vanguard and looking to build in the next few years. So if we just move on. So there's the 3 ticks. So in terms from the clinical development side, just to highlight, we want to obviously improve how we deliver care. So it's again how we take that operating model that we've currently got, and then very much from a patient perspective, but equally from a staff perspective, how do we evolve our services so we get excellent patient outcomes and provide the best quality care, but also make our new hospital one of the best places to work for in the NHS. And then that last point is we want to ensure that we right size our hospital to support our population and their future needs. So again, very much when we built the new hospital, we need to sort of future-proof it to ensure that it's fit for purpose for the next decades, to ensure that we keep continuing to provide that highest level of quality. So that's my sort of piece at the beginning in terms of the key headlines, and I will hand over to Abbas now. So Abbas, hopefully you're there.
Yes, I am here, and thank you, Jason. I think what Jason's clearly articulated is that you all know that we really need a new hospital, but the new hospital is a building, and it gives us the opportunity to shape the services that exist within it, and really to maximize its effectiveness. It has to embrace and acknowledge and being able to deliver those new services so that our patients and staff can look when the new hospital is open and see that the quality of care and the patient experience is improved. So that's really underpins the whole point of building a new hospital. So some of the things, and this is by no means an exhaustive list, I'm very happy to take comments and queries, and there will be opportunities to update on this in the future. But those of you that work, that are familiar with the inpatient area will know that so many of our wards have very few single rooms. So in terms of privacy and dignity and patient, and in terms of infection prevention and control, this is a real challenge to us. So although there'll be differences, small differences, depending on whether it's maternity or inpatients or pediatrics or neonates, there will be overall in the trust 70% in the new hospital. There'll be a minimum of 70% single rooms. So I think the lowest it goes down to in any area is about 60 to 65%. But so often it'll be in excess of that, and that will be great in terms of patient experience and infection prevention and control. And within that, particularly in the inpatient areas, in each there'll be on average one proper isolation suite. So that's fully ventilated with the correct air requirement, ventilation requirements, and ensuite toilet facilities. So there'll be one of those for every 8 bed spaces. So you're immediately starting to see how the environment in the hospital is going to be really different. And Tahir will talk a little bit more about the need to have flexibility, because in 10, 20, 30 years time, there almost certainly will be future changes of model of care and activity. So the new physical build has to be able to respond to that. One of the key things that will underpin the new hospital is that the ground floor, which is mandated to be your emergency area, will be a single floor. It'll be a really large floor, but it'll actually allow urgent care, the the children's area, the majors, minors, the short stay area, the same day emergency care area, and the frailty unit, all to be co-located in a single area, the centre of which will be a 24/7 radiology department, because we know that whatever the future models of care, there'll be greater reliance on diagnostics. So that's going to be a real transformation. It means that patients can be seen in a much more joined up area where the departments are much more closely linked, which is what the clinician, all the clinicians want, and being able to access rapid diagnostic imaging. So that allows decisions to be made much more quickly. And you'll see under the next bit, even in the elective service, which will be on the first floor of the new hospital, again, we'll be increasing the number of CT scanners and MRI scanners 2 to 3-fold, because even for the elective care, be it outpatients, be it one-stop shop, there's going to be an increased diagnostic demand for elective services to improve, diagnosis and quality of care. Jason's also alluded to the fact that inpatient care is going to need to change, because although there'll be high quality, more complex care going on in the hospital, we recognise that there are a number of patients who with better planning and coordination of care in the community could be stepped down to that care. So there will be a focus on that both within the ward area and also in the sort of command centre bit of the hospital. So we can very much be part of that Hillingdon integrated health and care system. Next slide. And again, in all eventualities, with the population that we've got and the complexity of the medical needs, there's going to be a need for increased critical care. So the number of critical care beds, which is currently 9, and a lot of you will know that the critical care area, the intensive care unit that we have, is one long corridor with very, staff do an amazing job, but it's very difficult to maintain really the highest levels of infection prevention and control and patient dignity. So there will be an expansion from 9 to 20 beds, but also appropriate single rooms to maintain those things. And again, medical high dependency is carried on in different parts of the hospital, and it's not really logically in the right place. So next to the critical care will be a 10-bed medical high dependency area, so that patients can be much more easily stepped up and down. And also it provides us that additional flexibility during the pandemic, such as we've been through, and indeed we're still going through to some extent. Children and young people, the services there, the key thing is to pick out that there will be a small area for transitioning patients. So in terms of age, that they can have a proper facility for, because they're not the same as a 2 or 5-year-old or as a 45 or 50-year-old. So that's a really exciting development that the paediatricians in the hospital are really excited about developing. Maternity will have much better co-locations. It'll build on its current excellent models of care, but the new environment will allow those models of care to be much better delivered in a more coordinated manner. And there will still be a co-located midwifery-led unit. And outpatients is an interesting area, because we know that with virtual consultation and that outpatient models of care and the way the outpatients is delivered is going to change. So there will be room for, of course, there'll be room for face-to-face consultations and much more support for procedures that can take place in outpatients rather than requiring day case or inpatient admissions. But also it'll be enhanced with digital technology to allow the clinicians to undertake consultations, both be it face-to-face or also virtual consultations. And so this is all going to really transform that sort of elective care piece for the clinicians, for our staff and for our patients. I think that's probably me done. Hand on to the next slide. No, it's me one more slide. Sorry. Jason's already alluded to this. It can't be, the things that we need to do to get the correct models of care are to really ramp up on our digital agenda. And so the new hospital will be designed with that in mind. And furthermore, you can have whatever great model of care you like and whatever new hospital you like, but if you haven't got the workforce that to deliver it, and those of you who are on this call will be familiar with this, that we've got to use the next 3 to 4 years to really understand what are the skills needs are to deliver the modes of care in the new hospital, and work really at pace to make sure that those are in place so that we can deliver the correct service. And I'm going to leave Tahir to talk a little bit more about the estates, because that's his area. So, and I've already run over time, so I'm going to move on.
Thank you very much, Abbas. And I'll talk a little bit about the building design. So with any building, the design starts here with an agreed functional content and a schedule of accommodation. And it's from this we build the building blocks of what the new hospital accommodation will look like. So we're at that 1 to 500 stage, which Jason and Abbas have spoken of. That is very much the first sort of stage of any building block, and where we look to put some proportionality to the building and how that functional content sits. So when we refer to a 1 to 500, what we mean is what you see on a plan is 500 times greater in its real sort of plan view, if you were to look at it. So as we move through the stages of design, you'll hear similar terminology, 1 to 200 and 1 to 50. Again, what that means is, as we go into the 1 to 200 process, is we're taking that high level schedule of accommodation and we begin to lay it out in terms of how the rooms within that department sit and correlate to each other. And then, of course, we take it to the next stage of 1 to 50s, which looks at something called ADBs, or activity database. And this helps us to actually see ourselves within the rooms and how that room will actually function in terms of its layout and its equipment and all the other services that sit within that particular room. Thank you. So the next slide here is just to give you a little bit of an illustration of how those then component parts are pulled together to make the whole building. So we don't just look at how the departments work in isolation. We look at whether, when putting them together, that we can meet the entire brief or the functional suitability of the building in both its horizontal and vertical axis as well. So similar to floor plans in your house, the 1 to 500s are no different from that. And then what we do is we look to detail those together so that they link through various strategies, and I'll come on to that in a moment. There has been a significant amount of work that's been undertaken through the clinical and operational working groups to develop these 1 to 500 scale drawings. So the next few slides, I'd look to just sort of walk you through the initial floors and look at some of the key adjacencies and how they relate throughout the building. Over the last few months, we have adjusted the design layouts in order for them to become more specific to the operational needs and the clinical needs that are required for those individual departments. And of course, it doesn't stop there. We'll continue to do this as we move into the 1 to 500 stages as well. This particular slide that you see is looking at that sort of vertical transportation, and we have experts that do this modelling. They're actually called vertical transport specialists, in other words, lifts. So here you can see the bit on the left, the diagram on the left is looking at how we keep visitors independent from patients, and then in the middle looking at the patient or the bed lifts, not just showing them in connecting from the centre of the building, but from the north and south elevations as well. And then coupled with that, we'd look to keep the FM lifts for the distribution of services, goods and waste to the extremes of the building, so that they can be easily brought in and taken to the relevant departments as well. There is further connectivity by the use of escalators that will be going into this building as well. So I'll move on to the next slide, which really just looks at by floors. We start with the lower ground floor, or the basement, as many people refer to it as. This is where we'd normally have a lot of the services and hard and soft FM types, the logistics as they come in. Now, even though this is in the basement or the lower ground floor, we do have, just where we see the soft FM type services, we have brought in natural light to that elevation, And in the centre of that building as well, there's a light well as well. So we're making all the attempts to bring in natural light, even though these services are located in the basement. Thank you. As you work your way up through the building, this is now the ground floor. This is made up of the emergency department, the main entrance, the dining and restaurant facility, along with a number of other sort of complementary services. What you can see here as well is, whilst we do have a deep plan arrangement within the sort of emergency department, the periphery of the building will have significant light. And again, we've made attempts to bring in more natural light, although it can be a little bit more challenging given the function of this particular department. But we are aware that there's a quicker turnaround here as well. Thank you. The next floor is where we have the outpatients and imaging department. Here we can see also the pharmacy department, which is located closer to the lifts, which I've been told is a bit of a bonus, because not only are they got good access to bringing their drugs and other items up straight into the pharmacy, but they do actually get natural light, which again is something that's not very common across hospitals in the past. The building also takes into account what Abbas mentioned earlier, this flexible construction and standard grid. So what we've looked to do is design a building with good floor to ceiling heights using standard methods of construction as well as modern methods of construction. And here this allows us to expand the building in the event that there is a clinical need or indeed any other need to repurpose the adjoining spaces. Coupled with the digital agenda, this makes these buildings more into intelligent buildings, which allow us to adapt and change over the many years of running the hospital. And you can see here just north of where it says endoscopy, there's a potential expansion space that can be used here as well. Thank you. This is a floor above, and then here we have the operating theatres, the critical care and medical haematology. Again, making this feel open and fresh, and a design that maximises bringing in natural light. We've brought in not just the peripheral daylight, but of course some quite considerable courtyards and light wells here as well. Pathology will also be pleased that they've now inherited windows in this particular design, which you can see there in blue, to give you that sort of feeling of openness and space as well. The well-being agenda is very important as we worked our way through the designs of this building. If I could go up a floor, please. Sat in the middle of the floors is the MEP, or the Mechanical, Electrical and Public Health. This is the bit hopefully most of you will never need to go into, but this is where the building is largely serviced from, so the plant and equipment, and this works up and down the building. Thank you. Going up a level, we end up into the general sort of maternity area. This is maternity and neonatals. Here we've also gone a little further as well, and we've introduced a staff dining facility as well, which is a welcome sort of addition to this area. And again, there's an opportunity to have some outdoor space at this particular level at balconies as well. So another opportunity to allow staff to get away from their everyday working environment. Thank you. The floors above are, this is the children's area with adult inpatient as well. The configuration that you see is made up of clusters of 2 wards, but north and south in a way. Each one of those is 28 bedded wards on either side. Thank you. Again, more of the same, but adult inpatient beds. And here you see one part of the building steps back, and that's really just to ensure that there's sufficient separation between us and the neighbouring properties as well. There's a big planning consideration that we're not just simply massing a hospital on the estate and it feeling somewhat overpowering, but rather fits seamlessly within the streetscape as well. Thank you. May I have the next slide, please? Thank you. And then we finish back onto the roof, further sort of just MEP plant, Here we may be able to introduce some photovoltaics, so the PV cells, which can help us bring in some, or meet some of our sustainability agendas as well. So we're absolutely maxing out the opportunities to not just have a building which is meeting the clinical brief, but a building that is warm and welcoming and is also sustainable for the forthcoming future of the building in both the short term and the longer term as well. Thank you. I'm not sure who's on next.
I think it's me, but just waiting for the live thing to move to me.
Okay.
Hi, Tahir, thank you very much. So that's a great overview of probably the first time a number of staff have actually seen what the building's starting to look like. So again, to deliver the building, there has to be two of the building blocks are one, that we have strong clinical engagement and we have strong program governance. So this slide deals with the clinical engagement, and you can see that there are a number of clinical working groups or user groups which deal with the relevant services. So you've got, reading from the left to the right, you've got therapy, which is chaired by Carol McCarthy, clinical support, Andrew Corns, our principal pharmacist, theatres, Al Myers, one of our surgeons, critical care, Elisa Cam, one of our critical care consultants, adult inpatients, Julie Vowles, children and young people, Richard Ajit-Saria, maternity and neonates is Nikki Wilkins, who's consultant midwife, planned care and cancer is Jay Ganapathy, one of the consultants, urgent emergency care, Jazz Johal, and finally radiology is Rakesh Patel. Now, we've tried to make it as multi-professional as possible, so the co-chairs, for wherever the co-chair is, wherever the chair is a doctor, there will be a lead nurse or AHP, that so that we get a real depth of clinical experience shaping the services and the hospital as a whole. And each of those groups has user groups has a number of individuals, and if you're one of those individuals, can I personally thank you. So that's made up of a large number of our clinical and non-clinical staff who really can shape those services in the areas in which they work, and those constituents will build together to make the main hospital. So those are the people that, if you want to approach, you should. I'm sure they won't mind you sending them some queries if they're not directed to Sarah and her team who are running the seminar. And then underneath that chart, you can see broadly the services that they are dealing with, and none of those will come as a surprise to you. So there's a really strong clinical input, and then it all feeds into the clinical cabinet, which I chair, and I have a deputy chair, a lead nurse. So deputy chair is Vicky Cook. The lead nurse for the clinical cabinet is Vanessa Saunders, who's one of our directors of nursing, and also we have Stella Barnes, who is the infection control lead for the trust, really important for the clinical aspects, but also for Tahir's estates aspects of the build. So there's a lot of experience that sort of sits clinically in this group. Last slide from me, please. So there are lots of areas in the hospital which we could sort of designate as non-clinical, but fundamentally the hospital is a sort of a sum of its parts. And, it's the front of house management. So this is the main entrance, the reception, PALS, bereavement, the cashiers. There's also really important that we have a good wellness and well-being spaces. And this is something that the New Hospitals programme is really putting a focus on, that we've got to look after our staff to be able to deliver this, the services that we need for a hospital. There's also going to be a rest area. So you'll all have rest areas in the clinical areas, but if you just want to get away at the end of a shift, or if you've got a half an hour break or whatever, and you just want to get away from the area that you work, then you can go down to this area and there'll be some rest facilities there. So those are all really important, as is a sort of command center. Command center sounds a bit like line of duty, doesn't it? But it's more to do with, you know, the operational center for the running of the, you know, of the patient flows and the discharges and the admissions. And that's going to be much smarter than it is in the current setup, where we're limited by the estate and by the digital infrastructure. And then another area that's going to be really important to our staff is going to be the clinical and admin area. So these are the shared areas which sit outside the wards, where, you know, our secretarial staff or other clinical and admin staff have their offices. And we've got to understand what that looks like and make sure that it's, even in these days of remote working, that there's enough space in the new hospital to fulfill that function too. And then you've got Tahir's group under logistics and estates. So those are all the kind of the non-clinical areas, and the assurance that they are contributing to the hospital as a whole will be through the redevelopment steering group, at which the senior executives attend, and they'll also be reporting into the clinical cabinet of how they are getting on. But again, it's just for you to recognise, as part of the 1 in 200 process, that there is good oversight on the development of these non-clinical functions of the hospital too. I think those are my 2 slides done.
Just wait for it to change over. Can you hear me?
Jason, I can hear you.
Yeah, brilliant. So thank you very much, Abbas. There's me with technology waiting for the little buttons. See, it says live now. Now I know where I am. So there very much is a high level overview of the sort of key developments on the design of the hospital and all the work that's going on. I mean, in summary, what we want to ensure is that everybody gets involved, because the key sort of success piece on the outline business case will really be the ownership by the staff that this is the hospital design that everybody is very much striving that they want to deliver and they want to work to in the future. And we really do believe that how we're designing it will provide the best model of care for our local population. So it's that key piece now of wanting to ensure people get involved. If you then, in terms of next steps, speak to sort of relevant leads in your area, the 1 to 500 plans, so all the pieces that Tahir sort of went through succinctly, they will be on our website today. Next week we'll be in the Hillingdon canteen, so again, in slower time, people can sort of see what's going on, and that will also allow sort of people to feed into the 1 to 200 process as well. There'll also be the staff surveys, events, and sort of a number of follow-ups, and we'll also have a public exhibition in June. So we'll very much hopefully be doing this on a much more regular basis, certainly beginning of June. But if we just, between Tahir, Abbas and myself, and just check, does anybody have any questions on what we presented, or were we all so good that actually all the questions have been answered? But I'll pause there.
Not currently seeing any questions coming through, Jason.
Well, I think that's then, I think it's a big tick badge to Tahir and Abbas today for well done of what can be confusing terminology in all of these things about 1 to 500s and 1 to 200s. Hopefully that's given you a really good overview of how we've sort of landed that initial 1 to 500 design, and then all the work Abbas is doing with all his colleagues with Tahir and the PMO about how we're taking forward the 1 to 200 designs. So if there are no questions, I'll let people get a little bit of their day back today. And we look forward to the next event, and hopefully no later than June. So just to say goodbye and thank you very much then.